as the colleagues are still entering, we would like to start on time. This is a 45-minute session, so we have quite a content to share with you in this time. I'm very pleased to be joined here by two exceptional colleagues, Dr. Rafael Romaguera from Spain and Dr. Federico De Marco from Italy. Both of them will share with us their knowledge in the field of vascular device closure. We're going to be speaking about the suture-mediated closure today, and we want to concentrate on patients with TAVI, but do not forget large bore venous access as well. That, I think, is the big difference. So can I show the slides maybe there for the beginning? Yes. So the objectives of the session are listed here, and I think it's important to emphasize what is here in yellow. Those are going to be the points we are going to try to highlight and discuss in more detail. So when you're applying suture-mediated closure, we think that echo-guided puncture is something which is important. Dr. Romaguera will show a case from his practice, a recorded case, where this, I think, is very nicely exemplified. Then we will speak about the mechanism of suture-mediated closure and what we think are the key principles for understanding to avoid any pitfalls. So I think that we need to understand how the device works in order to have the best results. And then last but not least, we are going to hear from Dr. De Marco about a venous outlook. So for me, that was also very interesting to see how this technology is applied in large bore venous access as well. So if you would like to see a visual summary of the session, of the flow of the session, how it will look like, this is something like this. So when we speak about echo-guided puncture, we are going to try to combine the imaging modalities that you use for planning the access. So the CT analysis, the echo, and we are going to try to draw this as well to try to explain it as much as possible and break it down into the details which are needed. So you see here roughly a similar image on the left of the femoral vein that was eventually, femoral artery that was eventually punctured in this patient. And then you will of course see the mechanism of the suture-mediated closure and how it works until the end of the procedure. And at the end, as we said, there will be also an example of large bore venous access. So that is the layout for the session. And that being said, I would like to ask Dr. Romaguera to start and show us the first part of his case.
Thank you. So, as Dejan said, we will try to go over the mechanism of closure with the ProStyle and also how to evaluate pre and post with both CT scan and echo based on a practical case that we have bring with slightly increased complexity. Okay, so this is a case of a 77-year-old gentleman that had a chronic renal failure. He was on permanent atrial fibrillation, receiving direct anticoagulation, anticoagulators, a little bit of anemia, and a platelet count of 187,000. He has obesity with a BMI of 29. He was around 80 kilograms with around 170 centimeters. So kind of a high bleeding risk patient with overweight or obesity. Okay? He had symptomatic aortic stenosis with preserved ejection fraction. The calculated STS score was 3.5 because he was young with no other severe comorbidities, but as you said, a patient that you can anticipate a risk of bleeding. By CT scan, he had a tricuspid valve, aortic valve, with these diameters that are not the scope of the incision. And on coronary angio, he has non-severe coronary artery disease that we decided to leave and treat because it was only 50% stenosis in LAD without angina. So one of the most important parts of the TAVI procedure is the self-evaluation of the CT scan. What I mean is self-evaluation is anything different than to submit the CT to the company and get just a PDF report. And that's very important to decrease the vascular complications. So it's very important to have your own software. It doesn't matter if it's three-dimension or series or whatever, but to see not only the diameters, it's not only right or left, but also the quality of the artery, the distribution of the plaque, the calcification, the angulation, tortuosity, and everything else. So in this case, we have here the 3 spots of the right femoral axis. As you can see there, in the right lower part, you have the bifurcation, which is very thick, and just above, at the segment of the common femoral artery, we have a posterior plaque, which has also 90 or 100 degrees of calcification, with an anterior segment which is quite preserved, with a diameter of 4.1 by 5.8. Then we have another soft plaques in the common iliac artery, and then at the bifurcation with the aorta, we have another calcified plaque, which is more concentric, but with a mean lumen of 5.8. So moderately diseased right femoral artery, but mostly in the puncture site. On the left segment, we have also a posterior plaque, as you can see in the right lower picture. Posterior plaque calcified with a slightly bigger diameter, 4.9 by 6.4. And the bifurcation with the iliac artery, you have another plaque, and then above, you have another calcification, which is 180 degrees, just close to the aorta. So in summary, we have a moderate tortuosity of the iliac segment and non-significant posterior calcified plaques with diameters from 4 to 5.5 or 6 millimeters. So here I will ask to ask my colleagues or to the audience, which axis will you choose? Will you go surgically or percutaneously, from the right, from the left, or will switch to another axis?
Rafa, let's try to poll the audience. So anyone would go for surgical cut down? Raise your hands.
No surgeons
that's
here.
Very reassuring. This case can definitely be managed percutaneously. Who would choose the right side? Raise your hands if you think the right side is better. Who would choose the left? Okay, I would choose the left. Okay.
And why is the big question.
Why? Rafa, I know you chose the left because that's the way to go. Why did you choose the left? Explain us.
So at this point, I think the left should be preferred because the quality of the anterior wall is better. I think on the left side, the plaque that we have is smaller. We have a lot of calcium with blooming artifact. I think that the plaque is indeed a bit smaller than what we see there because the calcium is you have a lot of bright in there. It's smaller. And on the right side, I think we have a bigger plaque with smaller diameters. And I think if you go, because I saw personally the CT scan up to the ligament, it's completely diseased. And in the left side, we had a spot in there. But honestly, what we can say is that we prefer the left, but please prepare both of them because first I need to check by echo, which will give you the definite answer.
If I may just say, I think this was a very important discussion because you were not referring to diameters only. When you start doing TAVI, very often you get from the companies when you start working with the diameter cut-offs for their devices. In terms of vascular access, the morphology of the disease in the periphery is very important. And I think you made this point very well discussing the two options. You were first discussing the plaque, the position of the plaque, anterior, posterior wall, and then you mentioned diameters. Now, in order to translate this knowledge from the CT scan into the actionable procedure in terms of pre-closing this patient, you actually need to do echo, I think. And we will now see from you how these femorals, which we just saw on CT, look like on the echo.
So as you can see here, this is the case. This is the right axis. This is the bifurcation. So we go from distal to proximal. That's my personal way to go. So you can see here that the huge plaque, which is posterior, but here also we have internal plaque and also some anterior plaque. And this is probably the limit. You see the branch that is going out there. Can I go back? Let me show you. Let me show you again, because the branch, this is the bifurcation, the plaque. And then you will see in the left part a small branch going out. So that branch, you see that branch at 9, that's probably the circumflex, the epigastric goes the other way. So probably that's the limit. Above that, we go to the ligament, into the abdominal part. So we cannot go higher. We have anterior plaque. It's difficult. You can try, but it's difficult to get a Suture there. And here we have the left. We have the posterior plaque, but the anterior wall is beating. It seems thin. We don't see that a lot of calcium in there. You see how it's beating? And that's distal, but if we go a bit proximal, that we will go now, you will see that we have healthier artery here. So here, this is still common femoral artery. There we have the branch at 9. So we have a segment which is still common femoral artery, and it's quite healthy. So as you can see here, you cannot do that with micropuncture, guided by angio, with your experience touching the pulse. So the echo is fundamental to get that spot. Otherwise, if you go just by angio with a PDF report coming from the company with diameters, you can, I think the successful rate will be much lower.
This was the right. Let's see the left now, right?
This was the beginning was the right, and this is the end was the left.
Exactly. So now there is a question, and I think you addressed it a bit. So what we can make an orientation on here is where the plaque is, so that we, of course, choose the puncture site, which has a favorable plaque distribution, if possible, not on the anterior wall. You shared one tip, how to not to go too high. Are there any other tips? Can we take radiographic markers not to go too high and cause a retroperitoneal bleed potentially?
I think that the best, can I write here? The best marker is the epigastric artery. The epigastric artery is coming to the muscles, so it's definitely outside of the abdominal part. So if you go on the CT scan, a branch that is going internally to the muscles, that's the epigastric artery. Everything below that will be for sure common femoral artery. If you go higher, you risk to be into the abdominal part.
And you see this on the ultrasound as the branch that you just showed?
Both in the CT scan and the ultrasound. The ultrasound might be a bit more difficult in some patients, and the other thing is because you have the femur, the bone there. After the bone, the artery is in the axial plane, instead of being like this, is going down. That's because there is no bone. So you are going after the ligament. So you are going into abdominal part. So if you identify the branch, that's a very good marker. Otherwise, in the axial, once the artery is going down, that's for sure abdominal part. So you have to go below that.
Maybe we move on and you show on the next slide. I think you will see then how the puncture is being done. And I think that many people will ask you whether you can puncture with so much plaque on the posterior wall. Let us now see how you did it.
So this is the puncture on the left. So I identified the best spot, which is this one. You can see there. Now it's starting to go down, so it's a higher puncture, but it's still in the common femoral artery. There is going down, that's abdominal. So we go a bit more distal, a bit more, a bit more, a bit more, a bit more. Here we have plaque, so then proximal again. This is the sweetest spot, okay? That's common femoral artery, and we are avoiding the plaque. And that's very, so first we do a small incision. And I think it's important because you first puncture and then you do the incision. It's complex to then open the fat tissue. So small incision, and then you have to see the echo going into the artery. It's just not putting the transducer and then the needle in another part. So you have to hold with your left hand, never release it, and then you see the needle going down at 12, you see? Then I push a little bit the anterior wall, I push, not yet, and then I push, and now it's bending the anterior wall, and now it's into the artery.
And there is some resistance on the anterior wall.
Yeah, you
and
have some resistance. I like to push a little bit to make sure, and then finish. And then this is not the finish. Then you check by echo how it's going. You see the wire at 12 going into the true lumen distally, so you don't need to floor if you do that. The wire is not going distal, and it's in the true lumen. There's no dissection.
Just one comment, Rafael, which I think is important. He always used the short axis view, the transverse view. He never imaged the artery in long axis. This makes it a lot easier. So really, following the needle in the long axis is difficult. If you just use the short axis, you're going to be 100% sure that you are in the middle on the anterior portion of the artery or of the vessel that you want to puncture.
So after you did that, what's next? Maybe your next...
So as he said, in longitudinal, you just can say that you are above the bifurcation and below the abdominal part, but you cannot sweep plaques, and you cannot make sure that you are in the anterior wall. So now we go for this one, I guess. So after that, you put a 6 French sheath. I prefer the 6. Some people are using 7 or 8. I personally think that if you use 7 or 8, you can have some leaking of blood, and then it's a bit more dirtier. But you can use 7 in patients with obesity, with difficult access, with previous surgery in the groin. So, but 6 is okay. Then you open a little bit the fat with a mosquito. Then you remove it, and then you advance the first ProGlide. It's very important to hold the ProGlide from the blue part. Never touch the 2 and 3 points, because otherwise you can detach the segment. I was showing there that this is our only femoral access. We are doing jugular vein without pacemaker, just to have it, radial, and then femoral. This is the only access. So we allow the patient to walk during the evening, the same day of the procedure. So when you are in the skin, you remove the wire, as you can see there. I'm holding the device from the blue part, not from the black part. Then you advance, and you have bleeding. So you are into the artery. I remove, then go back just 1 or 2 centimeters. We have bleeding. So I open the foot, and I pull it. You see, it stops bleeding. That's very important. If you still have bleeding there, you might be stuck in a distal plaque rather than in the artery. Then the needles. And you can see my angle is 45 degrees angle. I will explain it later. Then I cut the wire. And that's very important, the 45 degrees, because otherwise you can miss one of the foot.
So a question. Sometimes it happens that you do not see such a nice backflow. What do you do in that case? Do you go all the way as much as you can, or do you change the angle a bit of the device?
The flow should be there. Sometimes the patient has hypotension, because of the aortic stenosis, distal low flow, but it's not pulsatile, but you need to have definite some bleeding.
You need to see blood.
Yeah,
it's not always
otherwise you should not do that, because
exactly.
you might have some tortuosity, the ProGlide has not advanced, and you have the foot outside of the artery. Okay? So then we remove this ProGlide. I turn it to 11, and then we add a second one to the one. So just a small rotation. Otherwise, if you rotate a lot, for example, at 9 and 3, with the 2 feet, you can put the needles in the lateral artery, take a lot of tissue, and then create a stenosis or include a complete occlusion. So that's very important, just a small rotation. And then
Rafa, and this is especially important for this case where we see that there is some plaque towards the lateral portion of the artery. So minimal rotation is really needed, is all that it's needed.
So we have the second ProGlide exactly with the same technique, with a slow rotation to the one, just to the clockwise, and then in these cases that the arteries are not very straightforward, I prefer to use an extra stiff wire at this point to advance the sheath. so you avoid that the sheath is going through a tortuosity and you can have a dissection or a perforation of the vessel.
Extra stiff wire through the prostyle?
Through the second prostyle in cases with complex femoral arteries.
Personally, I go with an amplat super stiff,
This one.
short tip, 1 centimeter wide, directly into the
Prostyle.
in the second prostyle. Yeah.
Yeah.
I've
And
seen
if
some
there-
people using already the TAVI wire, the Confida or whatever. But personally, I think that you can deform the shape of the wire. So I prefer it's not that expensive to use extra stiff wire, and then to switch. And then in this case, we put a 14 sheath. Okay.
Yeah. Let's see what's next.
So this is the advance of the device. I think it's important to do it with fluoro in cases like this. It's just a few seconds of fluoro, and you make sure that the tip, sometimes that the tip is bent, so the sharp part of the outer curvature can damage the artery. You can go anywhere else. So a little bit of fluoro is my recommendation. This is the final result of the TAVI, which is not the point of decision. And then after the TAVI procedure, we close. So as you can see here, I use one mosquito with the blue and another mosquito with the first white. And I do that because in case if you mark with mosquitoes only the blues, in case of panic, you miss which is the white one of the first of the
So
second.
the
You have
recommendation
bleeding,
is
you
don't
have-
panic.
Exactly. But in case of bleeding, the patient is unstable, you can miss. So I prefer, as I told you, I mark the first one, but this is my personal experience. You can do whatever you want. So always the first on the left to remember. The first you close first, and second you close second. Mosquito in the second white. And then you pull the sheath with the one hand technique. You rotate with your first finger. We remove the sheath.
So it's interesting. You're here already pulling on the long one as you're pulling out the
I
sheath.
pull a little bit, but you cannot close everything. But
course,
in
yeah.
any case, this is a dry seal 14, so I will not close it. And then after that, first I pull and then I use the pusher, as you see, with one hand. This is the appropriate strength that you have to do, because if you pull a little bit and then you push the pusher a lot, you can stab the patient. You can do like that and even perforate the artery or the tissue fat. So it's just with one finger, you pull of the strip with your left finger and just a little gentle push.
And now you insert the short sheath?
No, this
Not
is
necessarily?
I don't like this technique. I've seen breaking many knobs with a new sheath. So then we close the second one, as you can see here, and then you have to evaluate. After you close the second one, you see if there is small leaking, which is this case. You can add a few protamine and just a little compression, and it will finish. And if not, you can add a sheath and decide whether if you need an additional device.
Rafa,
but in this case,
so let me ask you a question. When do you decide to remove the wire? So at what point? What do you check before removing the wire?
at this point, I just stop here to show you. So I close. People is trying to close completely the artery with the wire in place, which is impossible. So just a little close of the first one, just a little close of the second, and this part is only to check whether if you need additional devices. So at this point, I see, do we have a good sealing? Yes. I have I see the wire that is really close. We have not pulsatile, huge bleeding. Then I remove the wire and then I close again first and then second, and we finish the procedure. If I have here pulsatile bleeding with lot of bleeding, then you have to evaluate how big is that hole. Then you can insert a 6 French. If it's going nicely and there is no additional bleeding, you can decide whether to compress, and close again and compress and protamine, or add an additional device. If then you need to add more than 8 French and there is still bleeding, then you definitely need an additional ProGlide, probably the first step. And if not, another procedure.
I think it's important to discuss also there is an alternative, of course, way of doing this, an alternative technique where you put a short sheath and then you can visualize whether there is some extravasation outside. So that's also a possibility.
Yes, but my point is we saw the puncture with echo. we know that we are below the abdominal part. So we know because we saw the wire coming into the anterior wall outside of the abdominal part. So if there is no bleeding here, why we need an angio to make sure that the patient is not bleeding? Where can it be bleeding? In the brain, or So if you do angio-guided puncture or by pulse, of course you need that. But here we know that we are outside.
And can you share with us your tips? I mean, for obese patients, this was an obese patient, so there is a problem when you insert, or there is potentially a challenge when you insert a prostyle, because there is a long skin to artery distance, and then when you have to close also, you need to be sure that you put the knot down to the artery and not that the knot remains stuck in the subcutaneous tissue. So those two challenges with obese patients can arise.
Yeah, with obese patients, on the CT scan, you can be scared in most cases. You can see like about the pusher is 7 centimeters, so you can see 10, 12, 14 centimeters. But if you do, we call it like abdominoplasty, if the team is pushing the belly above with and is holding that, then finally it's very difficult to have just in that segment less than 7 or 8 centimeters. In that case, I would recommend to do a little bit bigger incision, more fat tissue debridation with the mosquito, and then to follow all the procedure probably with fluoro, because it may happen that you bend the wire, you think that you are into the artery, and by contrast, because of all the resistance with the sheath or the ProGlide or whatever, it was bent outside of the artery. So, and you create here, there a big hole. So check by fluoro that you are all the time into the artery, that the wire is not bent, create a little bit bigger hole and push the belly above. I think it's very easy as well.
If we could have maybe now, So one of the things that I think we can highlight from this case, that the distribution of plaque is very important. So basically, if we would have had the plaque here, then of course puncturing there would not be a good idea. However, with the echo guidance, we were sure that the plaque was on the posterior wall. And if you now look here on this image, the challenge that was presented, and I just want to reiterate, you explained it nicely and you could show it in the video, but I think it's an important key point of placing the device correctly. So it's the angle. So if you place your device like this, that the angle is like this. So this is your prostyle device. And then you have the foot pedals like this. So one will be here, the other one will be here. So when you try to puncture with the needles, what can happen is that you get through here, but then the needle may not catch it here. And that is the point where the device seems not to be working. And this can happen, of course, even more if you have an obese patient. So you need to pay attention to do it the other way. And this was nicely highlighted in the case, and I will now see it. So we now take the right colors for the prostyle. So you have an angle that is like this. As you can see, this is closer to 45 degrees that was mentioned. Now your foot pedals here are both going to be on the wall. So how usually I really feel it. So when you put the lever and you really pull it back, you can feel the resistance. You can feel that you're on the vessel wall. And then puncturing will be successful. So you will then be able to puncture both. And I think this was an important point for two reasons. One, we avoided the plaque. So you punctured the anterior wall, the plaque was more posteriorly, but you also moved away from the plaque, minding not to go too high to risk retroperitoneal hematoma. And the second point was the angle. And you nicely explained it. Especially in an obese patient, watch the angle is close to 45 degrees. It should not be like this. It should not be very flat. I think that was an important point.
Exactly. So
thank you very much.
the advice is go, if you have plaques, go as proximal as possible, okay? Because it may happen that you put here the ProGlide and then you have bleeding, then you open the pedals, you have resistance, you say, okay, I'm okay, I have bleeding, I pull back, I have resistance, let's go with the needles. But the problem is that you are stuck in a plaque rather in the arterial wall.
And then you can make a dissection and everything else, yeah.
But then you will know it because you have here your hole and you still will have bleeding. So you have bleeding, you pull back and you still have bleeding. Most likely you are stuck with your foot pedals in a plaque rather in the anterior
That's
wall.
an important tip.
So in that case, you can close the one again, close the foot pedals, pull it back a little bit, you still have bleeding, then reopen, and then pull, and you stop bleeding. That's the right point. But if you have plaques, go as proximal as you can below the epigastric artery or the artery going down into the belly.
Great.
This is the bone.
Thank you so much.
Thank you, Rafael. So that was a beautiful demonstration. So now we open the window and we look through the window into the large bore venous closure. We will see now the presentation, how it works. And to me, I do not do it, so it will be nice to see how it works. And I guess that the majority of you are also not necessarily involved in large bore venous access. However, it is nice to see how the device would work in a situation which is different. So we do not expect pulsatile flow. We do not expect plaques. We usually do not have CT of the vein, right?
Absolutely.
So how do we work it then?
So first of all, let's give this a state of the art. What happens? What people do for vein closure? The traditional vein closure, the classic, is the figure of 8 stitch, which has some pros. I mean, it's cheap, it costs nothing. It can close multiple stitches with a single pass, but it has some cons. Patients don't like it. I don't know if that's Italy. They feel more pain, but really they do not like it much. When you take it away in the afternoon, you have some late bleedings. And also, if you forget it there, you might have some compression on the skin and some skin issues. ProGlide in the vein has been used since many years. There are a few studies, not much around. This is a study which was published, I think, in 2008, so that's almost 20 years ago, taking into consideration close to 150 consecutive patients with venous access more than 10 French, which were closed with prostiles. And basically what we learned from this study is that it's a very safe technique and it's free of risk. There is a randomized study against figure of 8 stitch, which is so small that basically no conclusion can be drawn. It's just 20 patients per arm. What we see is that there is a trend towards a higher local bleeding in the figure of 8 stitch, 15% against 0%, again, but the numbers are so small that you cannot really draw any definite conclusion. There is a slightly larger randomized study, the SAFE vein. It has some limitation. It took into consideration some medium to large access veins, and again, it was against the figure of 8 suture, and ProGlide in the vein showed a significant lower time to hemostasis and lower time to ambulation. And since we do early mobilization of these patients, after mitral clip, for instance, after 6 hours, I want them to be standing up, pre-closure with the ProGlide is critical in my large vein access program. Let's see how you can do these techniques in practice and what are a couple of tips and tricks that you can use for this specific technique. The first step, as we've seen, it's again the echo-guided puncture. I know it's boring, but again, you use transverse positioning of your probe. You compress a little bit. You see that the vein is easily compressible. You puncture the vein. In this case, we are taking a second stick, so we place two veins, one close to the other, because I think it's a 3-clip case with also intracardiac echo, and so we do a double vein puncture, a couple of centimeters one from the other, and you see how we are following the tip of the needle and how we really precisely see the tip of our needle entering inside the vein. We place the second wire. At this stage, we do a little cut, and we are ready to, after a passage with an 8 French sheet to open up a little bit the vein, we are ready to deliver the ProGlide. How many ProGlides? And this is my slide. It's not Abbott's. Abbott's have different recommendations. This is how I personally do it after having done a number of these cases. Up to 20 for French. Recommendation is to use 2. I personally use a single ProGlide, and I'm happy with that. So this includes all ASD, PFOs with all devices, left atrial appendage occlusion, ECMO cannula can be closed with a single, and tear both in the mitral and in the tricuspid space. From 25 French to 30 French, I use a double ProGlide per close, and this is, for instance, when I do evoke cases, I use 2. And there are some cases where I also use 3, and that's above 30 French in the vein. And I think about cardiovalve, but there are also other devices which really require a super large venous access. How do we deploy the ProStyle? We advance, we open, we pull against with the classic significant tension. We then deploy it super normally and super standard. And you can do 2.
Excuse me, Federico, I have to ask here. Do you feel resistance in the same vein?
That's the next slide.
The next slide.
That's in the tips and tricks section.
Okay.
Okay. So you can place a second one. How do I do it? I leave the first one to give hemostasis to the first, but I don't want the plastic of the first one in when I deliver the second one. So I just pull it out before delivering the second. And at this stage, you see we have both implanted, and we are ready to advance the second sheet. In this case, it's a 14 French for intracardiac echo guidance. Oh no, that's the next slide. But this is trick number 1. You see, since the pressure is very low, how do you achieve confirmation of intravascular positioning? You press on the belly of your patient if he's sleeping, and you're going to have a few drops of blood coming out. If you're doing PFO with an awake patient or left atrial appendage with an awake patient with intracardiac echo, you ask the patient to do a Valsalva, and you're going to have bleeding to confirm the right positioning on the ProGlide. And the next slide will answer to your question. Do you feel resistance? So you feel less resistance because the vein is elastic. So be prepared to have more ProGlide out when you pull. The vein is elastic, there is less resistance, so it really comes up more. You feel a softer resistance as compared to the artery. And since it's easier to get stuck in the, I mean, not easy, but you sometimes get stuck in the vein. There are valves that can really trap you. It's easy to have posterior wall trapping because the vein is kind of soft. You really need to apply a good amount of tension and pull against the anterior wall of the vein. But remember, more ProGlide comes out as compared to the standard artery pre-closure. And the trick number 3, if you are in doubt, just use your echo probe, longitudinal axis. You're going to see very well the anchor of your ProGlide, and so you can easily confirm that you are against the anterior.
So you see the foot pedals, actually.
Exactly.
That's
you see
nice.
yeah. That's pretty easy with an echo, and it's also very convenient because it makes you sure that you are against the anterior wall. And that's just the final closure. If you have one ProGlide, you just pull it, and then you cut the sutures. this was the case with the ice, vein access and the triclip access over there. You pull the second one, and it's just as nice as this, no bleeding. You cut the sutures, and that's done. And this is just to show a final closure of a case with a 28 French device. This is, I think it's an Evoque. We are pulling out the delivery system. We pull the two sutures. We leave the wire just for a few seconds, and basically, very similarly to what we do with the arterial access, we pull both sutures. I also use a mosquito with plastic covers in order to minimize the risk of damage to the sutures. And then you pull away the wire, you cut the sutures, and that's it. Also, if you have some oozing, you can pull both sutures, and that usually stops the bleeding. And that's it. You are done. Thanks for attention.
So it's really a beautiful demonstration of something which is not maybe everyday practice for everybody. But one question, we have time. When you do this in arterial beds, you basically check either with angio or you check with ultrasound at the end of the procedure that the patency of the artery is preserved. Do you do something similar for the vein? Because the bleeding could be different from the vein, and it could take longer until we have a problem. It's not as obvious as from the artery. So what do you do after that last step?
I would like to go back to what he was saying before. If you are sure about your access, then you're sure also about the closure. If you do echo-guided access, I'm very confident. I checked that in the past with the echo. Now it basically never happens. Big issue do not happen in the vein. So you don't, personally, I do not check anymore.
You have not encountered,
yeah.
Okay. Thank you very much. With that, we have come to the end, and I would like to reiterate the main points that we have made. So ultrasound-guided puncture will help us define the plaque morphology, and will also help us define the plaque distribution at the puncture site before we insert the suture-mediated device, and that will also help us in the post-procedure, knowing that we actually puncture in the right place. What I usually do, I do check with angiography at the end of the procedure to make sure of the bleeding, but we've seen the ways how it works as well without it. And then at the end of the session, we've heard about the venous access, which I thought was very, very interesting, all the tips that you provided. So it seems to be working, so you're doing this on a daily basis, and I guess we will be hearing a lot more about it also in the future. Thank you once again for attending.